When you're thinking about this patient, it's like, okay, what can I put this patient on? Could I put this patient on a DPP-4 inhibitor? Now, DPP-4 inhibitors are nice. We know that in all the clinical trials, they're non-inferior. In other words, they're safe, but they provide no extra cardiovascular risk reduction. We know that there are 2 SGLT2 inhibitors that provide extra cardiac risk reduction, but they also don't tend to have hemoglobin A1C lowering as potent as a GLP-1 receptor agonist, which is why the ACE guidelines still say after metformin, GLP-1 receptor agonists in general are the preferred agent over the class of SGLT2. So when I look at this patient, she's got an A1C of 8.2%. If I give her an SGLT2 inhibitor, I can lower it 1%, maybe just slightly more than 1%, but I'm not going to get that robust lowering that I'm going to get with a GLP-1 receptor agonist. If this patient had had heart failure, if this patient had kidney compromise, then the SGLT2 inhibitor might be the preferred agent. But in this patient where it seems like atherosclerosis seems to be the issue, the GLP-1 receptor agonist, in my opinion, is the preferable class of drug for this patient.
The next step in treatment, if I were seeing her in clinic, would be a discussion first around lifestyle issues. Are there things that she can do to promote weight loss, a very important goal in the setting of diabetes? And then primarily point out to her that recent clinical trial data suggests that 2 classes of diabetes drugs are associated with cardiovascular benefit, preventing heart attacks, strokes, and cardiovascular death. And that in her setting with early cardiovascular disease and inadequate blood sugar control, that using one of these agents is really important for her. The trials are associated with clinically meaningful benefits on the order of 15 to 20% reductions in the endpoints that I discussed, which really puts it on par with the benefits of statin therapy, ACE inhibitors, arguably greater than aspirin therapy in this setting. So it's really important that we get patients on these medications when we can. In this case, the 2 choices for reducing cardiovascular risk would be an SGLT2 inhibitor or a GLP-1 receptor agonist. The SGLT2 inhibitor is a pill. The GLP-1 receptor agonist is an injectable. Her blood sugar control isn't so bad that we need the additional power of an injectable agent per se, but I do think that the evidence of benefit for reductions of heart attack, stroke, and cardiovascular death, the so-called MACE endpoints, is greater with the GLP-1 receptor agonists and the SGLT2 inhibitors. The new guidelines say either or, but I tend towards using GLP-1 receptor agonists where the dominant problem is cardiovascular disease, and more to using the SGLT2 inhibitors when the dominant problem is heart failure or chronic kidney disease.
I am asked all the time, what about your patients? How do you get them to take an injection? I think it starts with the provider. I think the needle phobia is a lot of times the provider, and that's a nurse practitioner, PA, physician. My patients won't do an injection. Oh, yes, they will. Just talk to them about it. A lot of times these patients have needle phobia because of the thought of what the size of the needle is. They think it's going to be a 20-gauge needle in their antecubital fossa like what you're drawing blood with. I've had plenty of experiences of taking a patient, showing them a 32-gauge ultra-fine needle, and having them do an injection in the abdomen. They don't even feel it. In fact, it's way less painful than sticking your fingers. We also have agents now that are once a week that you may even have a hidden needle. So there's a lot of ways to talk about this with your patient, especially when you say, here's the reason I want you to take this, and let them participate in the decision making. The other part of this is sometimes when they hear injection, they think insulin. So that's a different bias and a different prejudice and a different concern that you have to address with the patient. But I have had very little problems getting my patients to consider an injection if you sit down and you talk to them about the reasons and why you're recommending it to them.
It's always a bit of a touchy subject with providers, with primary care doctors, other providers, nurse practitioners, PAs, pharmacists, certified diabetes educators. as well as patients when we decide to go to injectable therapy. The truth of the matter is nobody really wants to take a shot. These new GLP-1 receptor agonists all come in pen devices. They're very easy to use. One of them in particular, dulaglutide, you never even see the needle. It's completely hidden. I sort of sell it to patients with the idea that it's like a magic wand. You just put it on your body and the magic happens. These drugs are associated with weight loss, very powerful glucose lowering, but no increased risk of hypoglycemia, absent the risk that comes from taking other medications at the same time, like sulfonylureas or insulin. I'm quite successful at getting patients to take those medicines, the GLP-1 receptor agonists, and in general, I think the vast majority of patients recognize the tremendous effect in lowering glucose and this hope and promise of reducing cardiovascular risk.